So this one is a case where we had a quagmire of sorts. Was this a vasculitis flare or was this an infection? So we started out with a 62-year-old male with type 2 diabetes who presented with with 2 days worth of chest pain. It was anterior, radiating to the back and inferiorly, as well as it was pleuritic and positional. It was worse with being supine, and it was improved while sitting. And vitals were grossly stable. His labs were also grossly stable, except for a mildly elevated creatinine. And his urinalysis was also pretty good, except for some glucose, but again, diabetic. So, so we scanned his chest. Turns out he has a bilateral pneumonia, as well as a 13-millimeter nodule in the lung. But also, he was on Bactrim. Why? Because 13 years ago, he was diagnosed with GPA, granulomatosis with polyangiitis. At the time, he had this really weird skin condition that no one could diagnose. And they did every test, and the only one that was positive was antiproteinase 3. He was started on therapy, symptoms resolved, and he was presently in remission. His last dose of rituximab was about 3 years ago. So at the ED, given that his vitals were stable, he was saturating fine on room air, evidence suggestive of a pneumonia. He was given azithromycin, ceftriaxone, and discharged on ceftriaxone, Ceftonir, and pain medications. Except he came back the following day for severe chest pain. So at this point, we were concerned. Did we miss something? Was this actually a GPA flare? So we contacted his rheumatologist, who agreed that the presentation could be indicative of a GPA flare-up. He also noted that the nodule was present on prior images, although only 11 millimeters. Overall, not too concerning. However, the rheumatologist had cautioned against using steroids. Even though steroids are the first-line treatment for a non-life-threatening GPA flare-up, in his case, given his diabetes, he had an exceptionally difficult hypoglycemic episode following prior administration. As such, we were recommended to use avacopan. This C5a receptor antagonist is a non-steroidal way of managing vasculitis, but the issue is that our location did not have that on formulary. So we had to put in the approval process and wait for it to arrive at the facility. Of course, we didn't just wait for it. We did labs. We got, and we also decided to do a thoracentesis to diagnostic and therapeutic purposes. We drained 800 milliliters of a neutrophil predominant exudate, and the patient's symptoms dramatically improved for about 2 days. The symptoms returned, a repeat scan was performed, found to have recurrent pleural effusion, drained again, but this time it was 1 liter of a lymphocyte predominant effusion exudate. By this time, the labs had come back. The C4 was reduced, which is somewhat concerning, but procalcitonin, ESR, CRP, C2, C3, C-ANCA, P-ANCA, and antiproteinase 3 were all within normal limits. And again, throughout this entire time, he has been afebrile, no leukocytosis, creatinine stable at 1.7. So was this a flare-up or was this a pneumonia? Well, it's probably a flare-up, right? He's been afebrile, white counts normal, and the blood cultures were negative, and the 2 body fluid cultures were also negative. But on the other hand, was this pneumonia with some renal issues? Because all of these labs specific for GPA were negative, except for C4. And the kicker was that even though we did not have the avacopan, his symptoms had resolved following the thoracentesis. We discussed this with the patient, and he proposed a third solution. He did have GPA flare-up, but it self-remitted. And as such, he wanted to go home. Fair. We sent him home with some Bactrim. We told him to follow up with our rheumatologist for the avacopan administration, and we also put in a Pleurix catheter for this weird recurrent pleural effusion. And then he came back 2 days later. Apparently, he couldn't breathe, and the Pleurix catheter wasn't draining anything. Imaging showed that he had a massive right pleural effusion again. So we sent him to IR to do a thoracentesis, but unfortunately, they were unable to drain it this time. So we sent him to CT surgery. They did a VATS, and they found a empyema. This time, it was positive for Prevotella oralis. And so the patient was discharged on Levaquin and Bactrim. At the 1-month follow-up, the patient was doing well. He was asymptomatic and back to his baseline activity. So what can we take away from this? Well, GPA is tricky. It is a multi-system disease. In addition to the nasopharynx, it can also involve the lower respiratory tract, like the pleura, in addition to the kidneys and the skin, as evidenced by this patient. As such, a flare can be indistinguishable from an infection, and as such is often confused as such. Additionally, recognition of potential anchoring biases is imperative. When I learned that he had GPA, I just researched GPA, and I found that a lot of the symptoms correlated, and so I thought, hey, it's GPA, but actually it wasn't. So in summary, you have to be cognizant and think critically in order to find the correct diagnosis. And these are references.
All right, great job. Do we have any questions from the audience? All right, here's one question. In retrospect, could this be both a vasculitis flare and subsequent secondary infection?
I do find that hard to believe, especially because pretty much all of the vasculitis workup, ESR, CRP, C2, C3, P-ANCA, C-ANCA, and proteinase 3, they were all negative. So really, we should have just used that as the hint that there was no evidence of any vasculitis involvement in this to begin with. Plus, again, he initially he was diagnosed with GPA because of cutaneous findings, not necessarily pulmonary findings, but again, we couldn't discount the fact that GPA does involve pulmonary symptoms, so sure. But again, looking back, probably wasn't GPA involved.